My name is Anne Ostenfeld, and on behalf of all the authors, I would like to present our AJOC publication, Mirtazapine or ondansetron for Hyperemesis Gravidarum, a randomized placebo-controlled trial, which is based on the VOMIT trial. Hyperemesis gravidarum is a severe pregnancy complication which is associated with adverse outcomes. Current treatment recommendations are based on limited evidence and are often not sufficiently effective in severe cases. And mirtazapine is described as an effective treatment in several case reports. However, there is no systematically collected evidence of its effect in hyperemesis gravidarum. Before initiating the trial, we were obviously concerned about the safety of mirtazapine in pregnancy, and we looked into this. A large systematic review on mirtazapine in pregnancy found no substantial evidence that mirtazapine was associated with adverse pregnancy outcomes other than neonatal adaptation syndrome. However, overall quality of evidence was low and results were conflicting regarding congenital malformations and spontaneous abortions. In a population-based cohort study including almost 2,000 pregnancies in Denmark, we found that mirtazapine in pregnancy was not associated with major congenital malformations, spontaneous abortion, stillbirth, or neonatal death. We thus concluded that mirtazapine was safe enough to initiate the trial. In the trial, we aimed to investigate the effect of mirtazapine and ondansetron in hyperemesis gravidarum, and we did this in a randomized, double-blind, placebo-controlled, multi-center trial recruiting in 7 Danish hospitals. The main inclusion criterion was based on the Pregnancy Unique Quantification of Emesis score, which is a validated scoring system to quantify symptoms of nausea and vomiting in pregnancy within the past 24 hours. It ranges 3 to 15, and the main inclusion criterion was Puke 24 score 13 or above, or Puke 24 score 7 and above if accompanied by either weight loss or need for hospitalization. Participants were randomized to oral treatment with either mirtazapine, ondansetron, or placebo for a duration of 14 days. We included 59 participants, and as showed here, we had a quite high dropout rate. In the mirtazapine group, most dropouts were due to side effects, whereas with ondansetron and placebo, most dropouts were due to treatment failure. We had anticipated the high dropout rate and had thus decided on a primary outcome on day 2, where we expected most participants to still be in the trial. On day 2, we saw a significant reduction in Puke 24 score with mirtazapine when compared with placebo, whereas the difference between ondansetron versus placebo and mirtazapine versus ondansetron did not reach statistical significance. This figure shows the change in Puke 24 score from baseline and during the intervention in the 3 groups. Mirtazapine is the blue line. It is clear that the difference between the groups becomes even more pronounced on day 4 and forward. Additional results included other patient-reported outcomes such as questionnaires on hyperemesis gravidarum symptoms as well as quality of life and sleep quality. All showed a tendency towards mirtazapine being more effective than both ondansetron and placebo. However, not all results were significant. We saw more side effects with mirtazapine, but the side effects were mild to moderate and resolved without sequelae. However, one patient in the mirtazapine group gave birth to a child with nasal cavity and heart malformations. The malformations were, however, considered unrelated to the treatment, as treatment was initiated at 11 weeks and 5 days of gestation, which is after the development of these organs. A major strength of this trial is that it's the first randomized controlled trial to investigate the effect of mirtazapine in hyperemesis gravidarum. Additionally, it's the first placebo-controlled trial with oral ondansetron in hyperemesis gravidarum. The trial is thus in accordance with stakeholder priorities. However, the study also has limitations, the main one being compromised power due to recruiting difficulties. We initially aimed to include 180 participants, but experienced low recruiting rates, which was partly due to COVID-19. However, the recruiting difficulties were also a result of this very challenging patient population. Many potential participants were too debilitated to engage in a clinical trial, and some were reluctant to consent to trial medication in pregnancy. Others declined due to fear of being randomized to treatment with placebo when they so desperately needed treatment. To conclude, mirtazapine led to significantly reduced Puke 24 score compared with placebo in pregnant women with hyperemesis gravidarum. Ondansetron led to a smaller reduction in Puke 24 score, which did not reach statistical significance. Optimally, these results should be confirmed in larger trials in the future. However, the patient population is challenging in the setting of trials. Thus, mirtazapine could be considered as an add-on or alternative treatment in treatment-resistant cases of hyperemesis gravidarum based on the results of this trial.